We have three large teaching hospitals in the center of Hamilton, one of which is a trauma, cardiovascular, busy general medicine and surgical hospital, the Hamilton General. We then have another hospital that's closely affiliated with the Oncology Center at the Juravinski Hospital, and a third center, McMaster University Medical Center, which is some adult outpatient work, but also has an embedded children's hospital. Lastly, we have a community hospital in a town not far from here, offering community practice. So a large multi-specialty, both community and tertiary care level facility. And we have a lot more referrals than we have capacity to book on a day-to-day basis. So it's a matter of streamlining, trying to be efficient, trying to triage appropriately, and then also, always just trying to keep up with literature, latest advances, working collaboratively with our, clinical and surgical teams, because we can't exist in isolation. We always have to be meeting what their needs are for their patients, and with different treatment and diagnostic knowledge, things are constantly in evolution. That's a challenge. We are partnered with another large and tertiary hospital in town, St. Joseph's Healthcare Hamilton, and we jointly wanted to work towards integrating and developing a quality improvement peer learning program in the city. The sentiment was that we didn't want to just implement a process whereby there was a check mark to say, yes, we do peer review. At the time, there were a lot of options for that kind of model, and that wasn't what people were looking for. We wanted a way that we could focus on education to make sure that this was a way of, rather than finger pointing and blaming, we really wanted to educate and move things forward. We also were looking for something that was nimble. We explored in a pilot project about a prospective process for doing case review and peer learning, and we were enticed by the opportunities that would offer. The product also did give us a sense that we could blend and adapt. In other words, having both that prospective workflow, but also developing some retrospective workflows for more urgent or emergent work that could mean that this work is also reviewed. So there were a lot of options that were available to help us integrate a program that could be meaningful and not just a, as I say, a tick box. I think the chief's responsible for working hand in hand with the hospital administration, directors and managers to make sure that we're delivering the best quality care that we can. We've also got to do the task of triaging and prioritizing, because as everybody knows, the demand outpaces the equipment and what facilities we have. Then also blending with, at a teaching hospital that we're at, we have three pillars that we really have to meet in terms of, clinical excellence, also involvement with our education programs, and lastly, research. Having people working where they're skilled and comfortable, having, a collaborative working environment where people work together so that everybody improves, keeps up to date, and moves the ball forward together, I think is a really important thing. There are, indicators that sit out in the radiology community in terms of report turnaround times, standardization of protocols and reports. And we're constantly trying to evolve towards meeting those goals. And, we did a lot of background work in setting up this program to launch successfully, and really collaborating with not only our own radiology team, managed PACS team, but also all the way up the chain with our IT people, our legal, our hospital quality committees, and our executive vice president medical, to get them on board on what we want to do. And they understood that there was value in this prospective model that we were developing. So when looking at other products, for instance, we're integrating an electronic medical record system into our hospital. The product that was paired with that would seem to us like a backward step if we adopted that. Those other products do not offer the opportunity to do prospective on-the-go reviews. There's obviously, it's good to have something, but what we had seemed so much richer and had so much more potential that we were interested in keeping it. When I come into a hospital rotation assignment in the morning, it's typically the first thing that I open up, because there will be cases saved from the day before that will be available in the pool for review. So I simply log on to the AI Cloud QA, and the eUnity launches up the images. I choose to start a review session, and some images will come on a list for me to select and pick up. We have stratified all of the image such that they are tailored to someone's subspecialty expertise. So, for instance, I am an MSK or musculoskeletal radiologist. So when I open up AI Cloud QA and I ask to start a session, it will only populate with the kind of studies that I do every day. So the advantage to that is that I'm reviewing what I'm comfortable with, and it makes sense also for me to provide feedback to the reviewer that this is an area where my expertise lies. So we have worked out an allotment that kind of balances the type of studies that need to be reviewed. For instance, it would take a lot more time to review a CT or an MRI than it would to review an ultrasound or an X-ray. So for my session, it accumulates points for what I do. So I open a list. Let's say I see an X-ray, I click on it, it will launch on my viewer. It will launch the image, and also if there are any other previous studies available for review, they will also be on my toolbar. I can then see the report that was dictated by the first radiologist. I don't have any patient information, so that is all anonymous or privatized. I also don't see who the radiologist was that reviewed it. We have a standard coding system that we developed, and we made this in parallel with a lot of the recommendations that are out in the literature right now, in particular the Canadian Association of Radiologists, whereby I code the case. I can give it a great catch, meaning if I think someone did an outstanding job, either with their detection skills or their report, I can go great catch. I can select concur, the meaning I agree, or there's options to select minor discrepancy or major discrepancy. I'm also allowed to put in any notes, and there's even an option for report recommendations. For instance, if I think that they could have used a different terminology or a different grading system, for instance, on it, I can provide that feedback. And then I hit submit, and then I'm back to the list and I can pick another case. The nice thing on the viewer, it actually has some taskbars at the bottom, and I can see how I'm doing for the day. Did I meet my quota? I can see how I'm doing for the week and for the month. I find those useful because there's some weeks that get busier than others. And if I happen to have forgotten, it's a good visual cue for me that maybe I'll just do a few extra cases today to catch myself up. In a lot of former peer review programs, it was done retrospectively. So in fact, the report from the previous study was open and you could clearly see who the individual was that had read that report when you were coding it. Versus in this instance, I don't see that, nor do they see when, if I have a discrepancy, for an example, maybe I've said right foot instead of left foot. And when my case got submitted for review, the reviewer picked that up. I then get an email message back to me saying, you may, log on to the system. There's a message for you. So I will log on. I'll see that I made that error and I can make an addendum. I don't know who reviewed that case. Similarly, we've developed a monthly peer learning education round whereby we are cycling our different subspecialty teams through presenting cases for an hour on a monthly basis. And each subspecialty typically presents twice in the year. They are able to harvest off of the AI Cloud QA software the list of all the cases that were reviewed in that subspecialty, and they'll try and take out the great catch ones, because obviously some learning to be done from people with the sharp eye or the sharp mind that have made a good detection or diagnosis, but also the cases that are being coded as minor or major discrepancy. And our subspecialty coordinators look down those cases to try and pull out which are the ones that would be key for shared learning and perhaps reviewing latest literature or imaging guidelines. In all of that process, they have no idea who the reporting radiologist was, who the reviewer was. So the entire thing being anonymous is really, quote unquote, safe. I, as a chief, don't receive any individual feedback that radiologist A has had 2 major discrepancies versus radiologist B has had none. I only get numbers and rates for participation. I'm just looking for people to participate in the activity. So in that way, it is safe and there's no blame, and it is a culture of learning. I think when you're doing any program like this, it just takes people a bit of time to get comfortable with it. In particular, you need to land on some principles of what is a major discrepancy and what's a minor discrepancy. And in the beginning, some people thought others were being a bit nitpicky, but we've always emphasized the golden rule saying, do unto others as you would like done unto yourself. So be very careful about how you, word, phrase, manage, package the feedback that you're giving to others. And I think after working with it now for almost a year, I think we've settled at a place where people are much more comfortable. It is worth highlighting the uniqueness of this prospective process because in a retrospective model, which, as I've said, we will be exploring in the near future for urgent work, but the typical model with retrospective is that the report has been made, it's been sent out to the clinician, and in many instances, action and management has taken place based on that report. With the prospective process, you have the opportunity to correct the report before the final report goes out. So in fact, certainly for the major discrepancies, the clinician would never have seen that final report because within 24 hours, this has been corrected. This is why right now, this is strictly being an outpatient process for the non-urgent work, but we'll look to find some timely and meaningful way to integrate the retrospective. But I think that's what makes it different and unique. And the fact that data isn't collected, I think a lot of people are moving towards that. We're currently just creating our first set of data for the year of 2021 to see where the participation rates were at. Did we set our targets at a level that was reasonable? Seeking feedback from, our radiologists. The worst thing we want to do is make this seem overly burdensome. This should be something that they want to contribute to. I think there is a sentiment that people are seeing value, particularly with the shared learning that's coming out in the rounds, the ability to share, as I said, different guidelines and literature and being able to marry them up to cases where this discussion has risen about how something could have been perhaps elevated to a better level or improved. If we look at it from a whole group perspective, it really advances us all. So I think what it really took was engaging all of the partners that would be involved with this outside of the department, in particular, up to my medical leaders. And, as I mentioned earlier, I think, IT and legal and within the department, getting all the way from the VP, director, manager to really understand what it was we were trying to achieve. For me, the most essential element was having one or two radiologists who were really passionate about this above and beyond me to help me in socializing and leading this. They became great catalysts for getting some enthusiasm and interest that had already had a groundswelling from our pilot project. But because I had a real champion at each of the hospital sites, St. Joseph's and at Hamilton Health Sciences, they really became partners in getting the nitty gritty, so to speak, done. We, at the time, partnered with or worked with a community of practice through Health Quality Ontario that had some tools that helped us work through readiness assessment, calculating our volumes, and eventually really working out the processes of what would we do. How would it look if we had discrepancies? And for instance, what would happen if a critical test result was discovered? We needed to have all those things outlined so we could explain to our clinical leaders what would be done in those cases. So having that all done ahead of time, we developed out sort of a comprehensive manual to go with it, along with quick step guides, started to socialize it through a steering committee and presentations to our radiologists, all done ahead of time before we launched, really made a difference. So the homework and preparation paid off because I think we had a pretty painless launch. The other piece was to not being too ambitious to develop the whole program all at once. As I mentioned, we've started with outpatients, thinking that this was a good place to start. We're looking forward to starting to disseminate our experience and are excited about the opportunity to also roll in, our urgent emergent work into a parallel process. But it's certainly exciting to be innovative in this form.